Wonderful. Thanks, Sam. And thanks for sharing those resources. So I would like to introduce Damian Devalk, who will chair our next panel here. And this is going to be a panel on healthcare quality, how to measure it, and experiments to improve it. So Damian Devalk is a senior economist in the Development Research Group on the Human Development and Public Services team at the World Bank. His research interests include health and education and the interactions between them. His current work is focused on evaluating the impact of financial incentives on health and education outcomes. So Damian, with that, let me hand this directly over to you to lead the session. I really look forward to hearing from all of the presenters.
Thank you, Maria. So we are starting 5 minutes early. Yeah? That's not an issue.
We are, yeah. I think that'll give us a little bit of extra time, hopefully, and some more time for Q&A. We ended the last session a little bit early, which gives us some flexibility.
Okay, that sounds good. So thanks a lot. So yes, thank you for introducing the session. I'll briefly introduce each of the panelists. And so then we will have 4 presentations and then a Q&A. And I encourage everyone to submit their questions in the Q&A chat box. So I'm Damian Devalk. I am a lead economist in the Development Research Group at the World Bank, working on health and education and the role of incentives. And I'll be the first speaker. Then Anya Sotman, a research economist in the World Bank Development Research Group, Human Development team, will follow. She's interested in how individual behavior and incentives shape optimal policy design, in particular in complex decision-making environments such as healthcare. Our third speaker will be Ishani Kanpal. She's an economist in the Development Research Group of the World Bank. She studies the impacts of health and social protection policy on women and children. In health, her research focuses on the measurement and improvement of the clinical quality of care, particularly through pay-for-performance interventions. And our last speaker will be Bert Osler. He's a research manager and lead economist in the World Bank's Development Research Group, Poverty and Inequality team. His current research focuses on finding more effective approaches to improve the well-being of adolescent females with the aim of increasing their human capital accumulation in the longer run. He's a co-founder of and a regular contributor to the Development Impact blog. So we'll get started. Remember everyone to submit your question in the Q&A box, and we'll have a Q&A session after the 4 presentations. I'm the first presenter, so I will share my screen right now. Here we go. Please let me know if you can see the slides.
Yes, we do see them.
Okay. So it's a pleasure to be talking with you about linking coverage and quality of care data to estimate effective coverage in health. This is joint work with Sven Nielsen and our late colleague, Adam Wagstaff. Big international initiatives like the Millennium Development Goals focused on increasing service coverage. This approach is now increasingly questioned, given that quality of care is often very poor. The concept of effective coverage aims at providing the bridge between coverage and quality, requiring that persons in need get the treatment that maximally improves their health. Our research shows how effective coverage can be decomposed into the product of coverage when those in need are getting care, and quality, correct or successful treatment among those getting care. We present estimates of effective coverage and its 2 components for several health conditions using household data. We show that whether it's coverage or quality, that's the bottleneck to better effective coverage varies by condition and country. And we discuss how facility-based data could be used to expand the set of measures. So this is what we call an effective coverage tree and its decomposition. We start with a population, and in that population, some people are in need of care for health condition X, and some are not. Among those who are in need of care, some will consult, and some will not consult. Among those who consult, some will be correctly diagnosed, some will be incorrectly diagnosed. Among the correctly diagnosed, some will receive relevant care, but some will receive no care or irrelevant care despite the correct diagnosis. Among those incorrectly diagnosed, some might really receive irrelevant care provided. Among those who receive relevant care, some will be correctly treated and the maximum health gain will be realized. But some will receive care that is relevant, but the maximum health gain will not be realized. And some might receive a mix of relevant and irrelevant care, and the maximum health gain will not be realized. We should also know that among those not in need of care, some might consult. If they are correctly diagnosed as not being in need of care, no care will be provided. But if they are incorrectly diagnosed, they might receive care even though that care was not needed. So we can see how effective coverage is the product of the percentage of person in need of care for a specific health condition who consult times the proportion of person consulting who get relevant care times the person getting relevant care who get optimal care. I'll give two examples. In orange, it's for antenatal care for pregnant women. Effective coverage will be the percentage of pregnant women getting some antenatal care times the percentage of women getting antenatal care who got optimal antenatal care. The second example in green is for pneumonia for children, and effective coverage is the percentage of children with pneumonia who got taken to a provider times the percentage of children with pneumonia taken to a provider who got optimal treatment. So again, we can see how there is this chain or tree going from prevalence of the health condition, then the person seeks treatment, that's coverage. The person is correctly diagnosed and treated, that's correct treatment. Or if we want to be more demanding, the person is successfully treated. So we have two definitions of effective coverage. One where we look at whether the person is correctly treated, and the other one more demanding where we look at whether the person is successfully treated. But in both cases, effective coverage is in effect the product can be decomposed as the product of coverage and quality. And we can represent these two dimensions, quality of care and coverage, into these effective coverage contours with quality on the vertical axis and coverage on the horizontal axis. And we see these curves where there is the same level of effective coverage, which can be driven either by quality or by coverage. So where comes the data? The data for coverage comes mainly from household surveys with testing about the health condition and information about care seeking. The quality of care will come from household survey with testing and care seeking and details of the treatments received, or from facility surveys, either from vignettes testing provider knowledge about the condition, or standardized patients, which measure at the same time knowledge but also effort of the providers, or direct clinical observation. Let's look at the advantages of and disadvantages of these different measures. In the household survey, we have real life treatment episode, but the information is subject to the quality of the recall from the patient or sometimes from the caregiver. In provider vignettes, we capture the provider knowledge, but we are basically looking at hypothetical treatment episodes. For standardized patient, we also capture the effort of the provider, but even though realistic, we are still looking at fictitious treatment episodes. Direct clinical observation has the advantage that we are looking at real life treatment episodes, but sometimes it's hard to establish the true patient's condition. And also it's subject to alternate effects where the provider know that they are observed and might behave differently. So now I'm going to move to some examples for some condition using household survey. The first one is antenatal care. The coverage is on the horizontal axis and it's defined as the percent of women giving birth who had at least one antenatal care visit. Quality on the vertical axis is defined as among those women, the person who had at least 4 visits with at least 1 visit with a skilled provider where blood pressure was taken and a blood and a urine sample was taken, that is correct treatment. We can see that in many countries and many surveys, coverage is quite high, but quality varies a lot. And so effective coverage varies a lot. We move to another condition, which is hypertension treatment. Here, coverage is the percent of hypertensive people who got treatment, and quality is defined as among those, the person with hypertension under control. So here we are looking at successful treatment. And we see that compared to antenatal care, quality varies, qualities and coverage vary quite a lot. So we see how the decomposition is different across conditions. Next slide, we are looking at the treatment of HIV, looking at one country, Mozambique, but where we have very good data. The coverage is the percentage of HIV positive people who sought treatment for HIV, and quality is defined with 2 measures of quality. In green is those people who sought treatment who are on antiretroviral treatment, which is the correct treatment. And in orange, we have among those, the persons who are on ARV and are virally suppressed. So a measure of whether the treatment was successful. And we look at the data for the 5 different Wells quintile among the respondents. We see that quality is fairly the same across the Wells quintile when we look at correct treatment, but if we look at successful treatment, viral suppression, it is much higher for the richer quintiles. Now we are looking at effective coverage for various conditions, and we see that it varies a lot. It's higher for pregnancy, for antenatal care, care during pregnancy, but it's lower for conditions such as tuberculosis and hypertension. The parentheses indicate the number of survey and countries for which we aggregate data. Our next step in this research will be to explore the use of facility data. We are looking at the advantage and disadvantage of the different data sources. One advantage with the household survey is that the measure of coverage and of quality comes from the same geographical area. This is not necessarily the case with the health facility data, unless the household survey and the facility survey have been conducted in the same location. Let me conclude then. We think it's important to go beyond coverage and consider quality of care. We think that effective coverage is a useful concept to combine coverage and quality. Our research project aims at operationalizing effective coverage by investigating how to measure it using existing data. And using household survey data, we show effective coverage varies by country, by wells, and depending on the medical condition. And finally, we discuss the potential use of facility survey data and its advantage and disadvantage. I'll stop here. Thank you very much. And stop sharing my screen and give the floor to Anya.
Anya, you're muted.
Thank you. Hi, everyone. I hope you can all see my screen. Thanks a lot for having me in this session. So I am going to talk about measuring healthcare needs and use with daily diary data. And to introduce why we think this is important, in curative care, where you're treating specific conditions, whether and when a given individual needs treatment, varies considerably based on their current unobserved, possibly unobserved health status. And moreover, many healthcare decisions are made in the home, for instance, the decision to seek care at a doctor. And in this context, then, misallocation is a core challenge of effective and efficient provision of acute care, because we would like to get care to people who actually need it, who are currently sick, but not to people who do not necessarily need it. And that in turn then creates also a measurement challenge, because we need to first define and observe who actually needs care and what care they need. And then we need to measure whether they actually receive that care. So what we propose and what we have used in our own research is to use health diary data to measure healthcare use and healthcare needs. This is based on 2 papers with co-authors Sam Brown and Mark Dean and Christine Blandall. And the original data was collected for an RCT of what's called the Action for Health program by our partner organization, Mali Health. And in this RCT, we studied the effect on care seeking. So care seeking is kind of the extensive margin of care, the decision to visit a doctor, for children under 5. And we studied 2 interventions. One we dubbed subsidies. That is, the NGO covered the clinic user fees for the 5 most common types of conditions for small children. And the second intervention is an information intervention where the families receive regular community health worker visits, and the community health workers teach the families health knowledge and care needs. So the idea behind this RCT and studying these together is that subsidies can reduce the underuse of care when there are access barriers, such as credit constraints, parents holding incorrect beliefs about care needs, or not taking into account externalities. But as we know, when you make a good free or very, very inexpensive, there can also be overuse from the perspective of the policymaker. And in that context, it might be the case that information provided by the health workers can improve the allocation of care by steering individuals, steering parents to use care for the children who need it, but not for children who don't need it. In order to investigate this, we collected 9 weeks of very detailed health diary data on symptoms and consultations. And then we use the symptom records to assess the need for provider evaluation. And we use the community portion of the IMCI, the Integrated Management of Childhood Illness Guidelines, for community health workers to make this assessment of need for care. So we have 1,768 children in our RCT. We randomize at the compound level with 642 compounds. The subsidies are provided through 2 public health clinics in the area, SESCOMs. And as you can see from this small summary here, our households are relatively poor. Only 13% have salaried employment. Only 46% of household heads are literate, and the households are large with over 6 members, but actually small for the area because these are relatively young families with small children. And the average income per person per month is approximately 26,000 SEFA, or $43. So now to the core of the data, we have this health diary data, and we collected this by in weekly surveyor visits to the households, and the surveyor assisted the family in compiling a health diary, which included collecting in total 15 different symptoms. We have about 60 days of data per child, and of those, on about 16 days, the child exhibits symptoms symptoms that have not received any treatment yet. And just to give you an idea what the most common symptoms are, so over 50% of kids have cold symptoms and 33% cough. These are both conditions that are in normal situations not in need for professional care, only when they last really long. But 32% of children also have hot skin or fever. 9% have diarrhea symptoms, and then 5% vomit everything. That's one of the 4 danger signs that we collect that would require immediate attention by a medical professional. We have a lot of other data, including on doctor consultations and medication purchases. And here you have a small overview. Our kids go to a SESCOM 646 times in total. And some of the children also see private providers 89 times. And then the large majority of medication purchases are actually informal or without any consultation, but these are also medications such as painkillers or ibuprofen or Tylenol that do not usually have a specific prescription or diagnostic need. However, as you can see from this data, our subsidy has a substantive effect on usage. We have only 138 visits without the subsidy, but 508 visits with the subsidy. And the reason for this is obviously this difference in cost to the household that is not covered by the subsidy or by any outside funding. What we don't know from this yet is if this care is actually care that is medically indicated or if it is potentially some form of care that is not necessarily needed. And in order to get at that, what we do is we group the symptoms in the health calendar into spells. We classify days according to the IMCI into care required or early for care. And then we treat any kind of formal healthcare, private or public, as an exit from the untreated spell, which allows us to estimate care seeking as a hazard model conditional on the ongoing illness spell. And this graph essentially summarizes what we find. So what you see here is the 4 treatment groups. On the left, the groups that do not receive the subsidy, on the right that receive the subsidy, and the top, those that don't receive the health worker intervention, in the bottom, those that do. So the full treatment group is down here and the control is up here. And on the x-axis, you see the days of the illness spell. We have nearly 4,000 spells. They last over 6 days on average. That's partly due to some really high outliers. And on average, 3 of those days are care required days, but there's a lot of variation. Some spells never need care, some spells need care on the first or second day. So what we then do is, what you see on the y-axis is the probability of seeking care on any given day. And we condition here on if this particular day is actually early for care, this is the solid line, or care required, that is the dotted line. And what you see immediately is 2 things. First of all, when you go from the left to the right, when the subsidy comes in, there's a huge, I should start with something else. The first thing you see is that parents, even without subsidy, use care much more often on care required days than on early days. And this, as we go from no subsidy to subsidy, you see there's this very large increase in care seeking, and that increase concentrates on care required days. So we get up to nearly 15% probability of seeking care on a care required day on the first day of the spell, for example, here. What you also see is when you go from top to bottom is that by contrast to the effect of the subsidy, the health workers do not seem to have significant effects on care seeking. And in particular, what they don't seem to do is that they help direct parents to get care, particularly to children who need it and less to children who don't need it. Or in other words, they don't seem to really improve the allocation of care as you might have hoped from an information intervention. So to summarize, we have an over 5 times higher probability of care seeking on care required days than on early days, which suggests to us that parents can distinguish between days where a kid needs care and doesn't need care just based on the child's symptoms and overall appearance. However, they underuse care on care required days, and here the subsidies really help. They increase care seeking probabilities by about 250%. And because of this difference in care required in early days, this means that over 70% of the new visits are actually IMCI recommended care. So in other words, the subsidies reduce underuse by more than they increase overuse, measured by the IMCI criteria. And lastly, additional information provided by the community health workers does not seem to improve the allocation further. Now, I want to very briefly talk about the second paper on treatment adherence to give more information about this health calendar. So we also have information on all medications taken, and we can use the health calendar to study treatment spells, so to speak, for antibiotics. And we can compare the length that an antibiotic is taken with WHO guidelines for treatment length. And this is what we do in this paper. There's an important caveat, and that is selection into treatment. So selection into starting a treatment spell, which depends on all sorts of characteristics of the patient. So we cannot study antibiotic adherence without accounting for this selection. And we do this by using a Heckman correction to control for selection on unobservables. And what's really interesting that we can show is that once we control for the symptoms that we collect in our health diaries, selection on unobservables, as indicated by the coefficient on the bias term, selection into treatment actually becomes insignificant. And in addition, we can also show that continued symptoms as measured by our health calendars are one of the most important predictors of adherence. The actual findings from the study were that there were overall extremely low completion rates of antibiotics, and in particular, girls have 10 to 14 percentage points lower completion rates than boys. And this difference is very significantly driven by boys who live in families with educated household heads. The household head is typically male, and boys who live in families with a male educated household head are the ones who are having much higher adherence rates than either girls or boys in families with less educated household heads. What we draw in conclusions in terms of allocation is that even when the costs are minimal, so the treatment is already purchased, households tend to underuse. And now here we seem to be faced with genuine information constraints because educated household heads seem to have a positive effect on adherence for at least some children. So to summarize, we think that health diaries can shed unique light on all sorts of at-home health behaviors. We only collected a small set of symptoms really, and they were directly linked to need for care, but these can also significantly predict parental decisions about care. And I would advocate for collecting more such health diaries to conduct more research on this mapping between symptoms and evaluation through a doctor, the treatment decision, and then finally health outcomes as the ultimate outcome of interest. Thank you very much.
Thank you very much, Anya. Now it's Ishani's turn.
Okay, thank you, Damien. Share my screen. Let me know if you see this, please.
Yes.
You do? Okay, great. Thank you. All right. So thanks, everyone. Today, I'm going to talk about pay-for-performance contracts in the setting of primary health care. This is work done with Sebastian Bahoff, who is at the Harvard School of Public Health. So pay-for-performance contracts are often used to resolve principal-agent problems. They can be used in the public sector in education and in health. In health, they're used widely in developed country contexts and increasingly in developing country contexts as well. The bank itself, the World Bank, has invested pretty significantly through 2 trust funds in trialing pay-for-performance trials, pay-for-performance programs across much of Sub-Saharan Africa as well as parts of Asia. At the same time, in health, information alone interventions, things like job aids, training, are commonly used as well. Now, what pay-for-performance contracts essentially do is they often use checklists to tie prices to specific actions. And in doing so, they're providing both information from the principal on what, or signals, if you will, from the principal on what actions the principal thinks are particularly valuable or important, as well as, of course, the economic incentive. So in this paper, what we're going to try and do is use a field experiment that we conducted in Nigeria as part of a larger impact evaluation survey, in which we attempt to disentangle these signals and incentive components of pay-for-performance contracts that are structured using a checklist. We're going to look at adherence to clinical protocol for labor and delivery care using WHO standards for what should be done. To give you a quick rundown of what we find, the first question we ask is, do the incentives matter above and beyond signals alone, so above and beyond the information? And the answer is yes. Does it matter if the incentives are cast as rewards or penalties? This is a bit of an unsettled question in the literature. We find no. But then in our context, rewards and penalties are equally effective. But then using a theoretical framework that extends Della-Vigna and Pope, we show that really, we should be thinking about whether rewards and penalties matter in the context of loss neutrality. And the way we set up our experiment, we hold the endowment effect constant, we hold the range of payments constant. And so it's not necessarily surprising that the agents are behaving in a loss neutral way. And then finally, another unsettled question in literature is whether there are spillovers and unincentivized tasks. So if you purchase a subset of tasks that are provided, that are conducted by the health worker, are you generating spillovers? And the literature has found yes, no, or negative spillovers, positive spillovers. We find positive spillovers, and we show that what you're going to find is going to depend on the degree of complementarity between the tasks. And so in our case, the tasks are complementary. So when you incentivize a subset, you're actually raising effort across the board. Briefly on the experimental setup, so as I said, we conduct a field experiment in Nigeria. We have a participation from 1,363 primary health workers who work in 691 clinics. These are largely female community health workers and midwives, but we also have doctors and nurses, as well as sort of some non-medical cadres providing care. As I said, we held a range of payments in the incentives arms constant, but in addition, sorry, I should take a step back and say we randomized participants into 3 study arms. The first is information alone, so we only use a checklist. The second is rewards, and the third is penalties. In each of these arms, to hold the endowment effect constant, we provide a participation fee, which is designed in a way to hold the average or the expected total payout constant across the 3 arms. And then we, in the 2 incentives arms, we hold the minimum maximum payout constant. Of course, the way the payouts the incentives are structured varies. In the rewards arm, you can earn on top of the participation fee. In the penalty arm, you would lose money that it would be deducted from the participation fee if you did something incorrectly. In all 3 arms, we gave participants this list of 7 commonly performed actions for labor and delivery. In the 2 incentive arms, we associated prices with 5 of those 7 actions. And then we're going to assess performance on the universe of actions that you could possibly do for each case. And so let me tell you about the cases. So we designed these 5 partographs. The partographs are a standard, commonly used across the developing world, including Nigeria, tool for the management of labor and delivery. We developed 5 of these cases, and we had them sort of independently reviewed by medical professionals, because Sebastian and I are economists, so what do we know? So, we wanted to make sure that these were correct and meaningful. We divided actions, as you can sort of tell here, we have incentivized actions and we have unincentivized actions. But then we also have actions that are not on the checklist at all. And this is how we're going to measure spillovers from incentivized or listed actions onto ones that are completely unincentivized and not listed. So here's sort of the graph that tells the story of the paper. We find that both penalties and rewards strictly dominate information alone. We don't actually find a difference between penalties and rewards. They're equally effective. This 4% increase in overall performance, overall adherence to protocol is this 4 percentage point increase translates to about an 8% overall increase in performance. And on the specifically incentivized actions, this translates to about a 20% increase in performance. We don't actually, we don't have a pure control arm because the partograph itself provides primes on certain actions. It provides some information. And so we didn't feel that we could genuinely have a true control arm. But what we can do is look at performance on unlisted actions. We randomly chose 7 out of the 15 actions possible to incentivize and to list. And so we can look at what happens to the other 7 actions as a benchmark case. And we don't actually find that information alone leads to a significant improvement, at least in this setting, over nothing at all for those actions. Then moving on to spillovers, the way we calculate them is to look at performance in the reward arm over and above the information arm on actions that are unlisted. So the 8 actions that are not on that checklist at all. And we find that both penalties and rewards significantly increase performance on these actions over and above information alone. This translates to about a 14% increase in effort on these actions as a result of incentives. Now, like I said, this is an experimental task. There are no real patients involved. So, you might say that this is just noise, that what we're picking up is just noise. There are a couple of things that suggest that that's not the case. So first, we're able to replicate overuse or overprescription that we might expect in the real world. So we paid for some unnecessary tasks. In one instance, we had a task that was actually would have been harmful. And in some instances, the workers actually responded to those incentives and said, that they would perform those tasks. This is a commonly documented feature, this sort of overuse of, in particular, of healthcare settings in low and middle income countries. We also find overuse in cases where there are no incentives associated with the task, or even when the task is unlisted. Again, something that, for example, our colleague Jishnu Das and Anya's own work has shown is not uncommon in LMICs. On the other hand, on the flip side, we also find that participants identify tasks that are completely unincentivized, that are not even listed on the checklist, but in fact are clinically necessary. So they're not only responding to the incentives and just saying whatever they need to say to earn the incentive. This is actual meaningful measure of what they would do. Now, another thing you might worry about is, all this is picking up is knowledge. I mean, since there's no real patient involved, how do we know? So this was conducted as part of the Nline survey of a pay-for-performance trial in Nigeria. And for that impact evaluation survey, we conducted clinical paper-based vignettes of health workers' knowledge of clinical protocols in maternity care. We can include their score on the vignettes, a fully interactive specification, and our estimated impacts of the incentives, including the spillovers, are totally robust to that. And so that suggests that we're not just picking up knowledge, so this is picking up something above and beyond that. Knowledge in itself can be sometimes significantly correlated with performance, but it doesn't change the impact estimate of the incentives. And then finally, there's new work by Claire Lever, Owen Osier, Peter Thurniels, and Andrew Zeitlin that suggests that participation in a pay-for-performance trial can actually cause workers, this is teachers in their context, to exert greater effort. So you might say that, the fact that some of our health workers were participating in this P4P trial when we played this or did this experiment with them is driving the result. And so again, we can control for participation in the P4P trial that had experimental arms as well, that are cross-randomized with our task here. Again, our estimates are robust to the inclusion of those interactions. There we go. So to just conclude, in summary, I showed you that we find that incentives matter over and above the signal provided by information alone. We, in our context, don't find rewards and penalties to be significantly different, and we show sort of theoretically why that might be the case. We find positive spillovers from incentives, and again, through our theoretical framework, provide a way to think about where you might expect spillovers and in which direction they might go. Finally, the question is sort of an open one. I'm going to leave it relatively open, which is it worth it? So in general, as I said, we're finding an 8% increase in overall effort. We're finding a 20% increase in performance on directly incentivized actions. But because total effort is also higher, we are actually, even though we designed the expected payouts to be comparable, they are actually higher by about 5% because the incentives outperformed information alone. So, that's sort of just a way to think about whether it's worth it or not. And I will leave it at that. Thank you.
Thank you very much, Ishani. Burke, you are our last presenter.
Okay. All right. It's a pleasure to be here, to be part of this panel. I'm going to talk about family planning. It's a kind of a long-going project on family planning in Cameroon. And what we've done is we've developed an app, a tablet-based app for nurse counselors to use to improve the quality of family planning counseling, especially among young people with an idea to increase the take-up of modern contraceptives and prevent unintended pregnancies. We're using an adaptive experiment to test whether the new approach that we take in the app compared to the status quo approach that's been done in the family planning world is effective. And while we're doing that, we want to make sure that while we're increasing take-up, we don't decrease client satisfaction or client welfare. So we want to make sure that we measure quality of the services as well as the quantity in terms of the take-up. So, and that's how the kind of like quality of healthcare services fits into this topic of this session, as well as kind of measuring development. There's some interesting data features that I'll touch on quickly. So let's here. So I'm not a PBF person, but we are working in Cameroon in a PBF setting. Apologies for the typo. But healthcare facilities are given payments per unit of service provided. Ishani referred to the checklist. That's a good description. So there's a list of services that the government wants to pay for, and then it essentially counts them, right? But increasingly, there is now demand for quality of the services to be incorporated into the payment system. Currently, it's more of a binary thing where there's a quality control person that just gives a thumbs up or thumbs down for the facility, but there isn't necessarily a quality indicator, more like a continuous indicator on which you would actually make payments. So, and that's a constraint, and people have been trying to figure out how to do this. Here in this study, as part of what we're doing, we're going to focus on measuring a kind of like a simple to-do 10-item instrument developed by the POP Council to measure quality of family planning. And if we can validate its predictive validity, then it can potentially be used in PBF in Cameroon and elsewhere. Right? Now, I want to talk quickly about family planning and what we're doing. Historically, the focus in family planning counseling has been on the model that's an informed choice model, where individuals are given really extensive information to make their own choices. And the interesting thing here to note for those of you not familiar is that the health provider is actually often discouraged from opining at all about the desirability of one method over the other for the fear that they might unduly influence the clients. So it is really a kind of like, here are some choices. I'll tell you a little bit about them in an extremely dry fashion as I can, and then I'll ask you what you want to do, right? Now, more recently, people have proposed that maybe that's too conservative and there can be a shared decision-making model where the facilitator, the counselor, could give some more information and even make recommendations without undue influence, without being disrespectful or coercive. Right? So what we've done after some formative work in Cameroon is we've developed a job support tool. We're calling it an app because it's a tablet-based thing for providers to use that actually incorporates this new paradigm shift, like a shared decision-making approach into the FP counseling. And we've developed this app over a long period of time with OBGYN professors, both in Cameroon and in the United States, with nurses in Cameroon, as well as experts from the World Bank, Ministry of Health in Cameroon, Harvard Public Health School, etc. Now, what the app does is actually not that different than what a counselor would do, but it structures it and records it so that essentially we know that each time we're going to get a structured interview. And during this interview, the app makes sure essentially that the counselor hits all these important notes about privacy and checking with the clients about their fertility goals and needs, get them settled in and comfortable to talk, their birth history, their previous experience with contraceptive methods, especially what kinds of side effects are really important for them, and other aspects of things such as concealability and things like that, as well as their medical eligibility, which is super important, of course, for not giving them a wrong method that might contraindicate with a condition that they have. So on the kind of apropos to this session is that the collection of these data into the app, which get then synced immediately into the cloud and get de-identified and shared with us, it's a hugely rich data set on all of these things that the counselor is telling people. So these things always happen at these sessions, but they're never recorded. So this is now a rich data set of all these counseling sessions in which we know all of these things about the clients and their answers. Now, what happens when you come to the end of the session and the client actually has to make a choice? That's where we introduce a little experiment where we randomly assign people to either the status quo model, where the client is essentially shown 4 cue cards for the 4 methods that are offered at the hospital, and asked, which one they would like to discuss. Whereas in the new paradigm, the algorithm actually ranks the methods, and then the counselor asks the client whether they would like to start by discussing the most suitable method for them, right? Now we're testing the effectiveness of this approach at a women and children's hospital in Yaoundé, which is the capital of Cameroon. So you should note that this is one hospital, urban setting, and it's a pretty good hospital. So you should keep that in mind when you're thinking about, let's say, more common kind of rural sub-Saharan African settings where the service quality may be lower. Like I said, we randomize this counseling approach and then we cross it with discounts for family planning methods, especially because we think some of the clients, especially adolescents, don't have enough money, are credit constrained, so they can't buy these products even when they want them, right? Now, again, apropos to this setting, I want to mention that healthcare settings like this, in which a stream of new clients are enrolled into a clinical trial, can be enrolled every day because they're walking into the hospital every day seeking services. They're highly suitable for adaptive experimentation, which is something my colleague Anya Sotman does as well. So here, actually, what we're doing is an adaptive experiment where even the initial probabilities of assignment to different arms is informed by pilot data and our priors by the context of the client. So for example, adolescents coming to a different department may be more likely to be assigned to one arm than adults going to another department. And then what we further do is that each month we look at the data, and depending on how things are going, we adapt those assignment probabilities towards something that's better, which makes the trial kind of more ethical, minimizing regret during the trial, as well as allows us to potentially reach an equilibrium to find the winner faster. Now, I'll show you some data from the pilot phase that we've done. Thanks to the pandemic, we've had an unusually long pilot phase that you can see at the bottom. We had 990 people over the course of 14 months or so coming to the hospital seeking family planning counseling services, right? The interesting things to note here, 2 things. One is that a lot of people who are counseled leave the hospital with nothing. And you should note that these are people who are, childbearing age women who are in need of these things. So you can see that about 2/3 of women leave the hospital with nothing, and only about 30% take up a long-acting reversible contraceptive, such as an implant or a IUD, right? Discounts are extremely effective. So we take the take-up from 30% to 50%, or the amount of people leaving the hospital with nothing from 64 to 45%. And you can see on the right-hand side that they're particularly effective for adolescents. Whereas there's not much of a gradient of the discounts for adults, there is a huge gradient for adolescents, and it's much more important for them for the products to be free, essentially. And in fact, when they're free, their take-up rates are higher significantly than adults. Now, this is a nice thing to show here because it kind of debunks the myth that, adolescents these things aren't really suitable for teenagers, and there's all these other inherent reasons why they're not adopting. In fact, when they're in a high quality setting and they're offered these things, and when they're free, their take-up goes up hugely. Now, I want to show you the kind of the 2 counseling regimes that we have recommending versus the status quo. This pink is the status quo here. So at the high prices, only 17% of the people take up a LARC when they're counseled with the status quo method. But when we tell them that this method might be the best for you, that goes up to 37%. So it more than doubles it, right? So the information in a way, or the nudge for recommendation, is so strong that increases their willingness to pay to a really high level. But then you also see that you now follow this green across the different price discounts, and these people have become completely price insensitive, right? Further discounts do nothing for them. Whereas people who are not informed that there's a potentially a most suitable method for them, right? They're waffling about what to take. As soon as you tell them, hey, actually, we'll give you a discount, their take up doubles and then goes up a little further when you give it for free. And then in the end, these take up rates are identical. So in a sense, the only difference here is the cost effectiveness, because obviously giving them a different type of counseling session without having to pay all these subsidies is a cheaper version of getting higher take up. Now, of course, you might say that, well, when you do that, are you really forcing people to do it, or are you nudging people in more like a shove? And are they unhappy? So let me show you some data on that. So we use this 10-item instrument that I told you about, developed by the Pub Council. It essentially tries to capture 4 domains: respectful care, method selection, effective use of the selected method, and the continuity of care. Now, here are the numbers that we get. You see that the Ashkopi, the hospital that we have, Luca and I know very well that like they have a space problem. So privacy is an issue. You know, people are hearing what you're saying, and then people are seeing you getting counseled. There's no doubt about that. Fortunately, Jain et al. Paper actually shows that this is not predictive of future use. So even though it's not desirable and the clients don't like it, it doesn't really predict their future discontinuation of a method. Where this does really well is all the other aspects we're doing really, really well. 80 to 90% of the clients are very happy with all of these things. And you can see that these dots are actually from the Jain et al. Paper of the kind of like business as usual in India. What are these aspects? Are you told about the side effects? Are you told how to manage these side effects? Are you told about warning signs with the selected method? These 3 things our formative work shows, and there's other work that shows, are hugely predictive of future discontinuation. And we essentially double those business as usual numbers in India. 96% are told about their side effects and how to manage them, and etc. And this is not surprising because the app is kind of really forcing the nurses to do so. Now, we looked a little bit to see if there's any difference by provider experience, and experienced providers are doing slightly better, mainly in telling people like come back to switch if it doesn't agree with you, but other than that, not much of a difference. Furthermore, really encouragingly, the 2 counseling styles really don't differ in this matter. So we're actually able to increase at full prices the take up with this sequential method without decreasing the quality of the services. Now, when we finally look at also the measures of satisfaction that are not part of this tool, people are saying they're 95 to 100% satisfied in terms of with the quality of services they received with the consultation and likelihood of returning to this hospital for similar services. Now, last slide, what's next? We'll be continuing the adaptive experiment that we started last month until at least the end of this year. And what that will do is it will actually allow us to come up with optimal policies in terms of both the subsidy and the counseling regime for different subgroups of people, such as adolescents and adults, as well as people who are postpartum or people who haven't given birth recently and things like that. We'll also be interviewing the clients at 16 weeks and 12 months after their initial consultations, and that will actually allow us to validate these quality measures to see if they really predict well, if people are still continuing to use the method that they chose because they got a better match. And then in 12 months, we'll be able to see whether they're less likely to be pregnant or not, which should follow from the discontinuations. And that will essentially allow us, if this is really predictive and nice, we will have validated and replicated the results of Jain in India in an urban African context, maybe another step towards potentially being able to use this type of thing in PBF payment systems. And then finally, the data collected on satisfaction and quality of care is really encouraging for us, even though it's just pilot data yet, to show that while our new approach can actually increase the uptake of LARCs, especially among adolescents, it's doing so without sacrificing client welfare. So there isn't this worry that our app is kind of like too forceful in recommending people something that they don't want and they feel pressured to take up something and things of that nature. Thanks very much.
Thank you very much, Burke. So thank you to all presenter for this very interesting presentation and research. Now it's time to move to our question and answer session. I remind you that you can put your question in the Q&A box. We currently have 3 questions, so let's start. The first one is for me, so I'll try to be quick. Nice words, thank you, Michael. Or Eddie, I don't know. Are these data yet at the point where they've been used to inform health policy decision? I will just answer that we are still working on this data. What we've done over several years is insist on quality of care, for example, on the work on PBF, performance-based financing, that both Burke and Ishani mentioned. We really insist that it's important to also incentivize quality of care. And also, I think at the end, we want to push for maybe similar to what we had in education, where the message is very clear that what matters is not only how many kids you get in school, but also what they are taught. We really want to push this idea that in health, it's not only important with people to show up in the health facility, but quality of care need to be measured, incentivized. One thing where, for example, there could be a lot of progress is in introducing more measure of quality of care in routine health measurement information system, HMIS, in which currently most of the indicators are still more coverage than quality. I'll stop there, and then I guess I'm reading the next question, which is for Anya. Was there any concern of social desirability bias, or that respondents would increase their understanding of symptoms in response to the frequency of interviews?
Yeah, thanks for this question, Michael. I think this is a question about Hawthorne and observer effects, and maybe both how they change reporting of actual symptoms. So this would be the social desirability, and then also how they maybe change the behavior of respondents. And I want to answer to both these concerns. So these were definitely things we thought about a lot when we collected this health data, because we were very concerned that we would affect either how people talk about the symptoms that their kids have or how they respond to them. So in terms of reporting, we did a baseline survey where we tested this health diary collection. And what we saw there is that there was definitely a spike at the beginning in terms of symptoms reporting in the first week of this data collection. And then there was a pretty significant drop off in terms of the number and frequency of symptoms reported. And we took this to mean, similar to some work that Jishnu Das has also done, we took this to mean that there was a significant habituation and that people became less sort of over attentive to the symptoms of their kid, or maybe also over reporting symptoms, possibly in a way, in an idea of convincing us that there was a lot of illness and that there was intervention needed and so on. So we think that reporting became closer to accurate over time. And then we visited these families again the year later and collected the same type of data again. In terms of behavior changes, so again, we were very worried that our subjects would take hints from the way our surveyors asked questions and so on in terms of their behavior or response to symptoms. So we did very careful training of the surveyors and attempted to instruct them to ask questions very neutrally. So for instance, they don't ask, does your child have a fever? They ask, was the skin of your child unusually hot or cold this week? They were also instructed to always emphasize that they had no authority and no qualifications to give any kind of health advice or health services, and that anyone who was concerned about their child had to see a doctor. And more generally, we also instructed them not to show any kind of surprise or positive or negative reactions to reported behavior and so on. Having said all this, I think we cannot rule out observation effects simply because we have no other way of measuring these types of things besides actually doing these health diaries. We were in the end coming down on the side that we need some way of measuring it, and this is the best thing we could come up with in some sense. And I think the choice was not so much, is there this way or some other much better way, but it was more, is there this way or no way at all? And we decided that it was worth collecting this data. But your point is very well taken, that that there could be such observer effects still taking place that we cannot quantify completely.
Thank you, Anya. Next question is for Berg. Very impressive work. Can you say more about the adaptive trial part of this work? How much faster was the adaptive trial compared to if you had done a static trial?
Thanks, Michael. A long time since we've seen each other. So in our case, we just started the adaptive part of the trial. So I can't say how much faster it's going to be. Simulations suggest that it's not going to be that much faster. But the thing that it's going to do is that we simulate essentially this against the static trial. And what it does is it's actually maximizing what we want to, our objective function better. So what we call kind of like negative loss is actually getting maximized more in the adaptive trial than in the A/B test in simulations. Now, if you were to Google, and you can, but if you email me afterwards, I can guide you to the pre-analysis plan that we registered. So you can see all those simulations actually in the pre-analysis plan and examine them yourself. But if you just Google Don Green's website on kind of like 10 things to know about adaptive experiments, there he shows kind of like examples of like, or you go to Google's pages on kind of like how they do these things. They really claim just much faster convergence to kind of like on a day-to-day things on advertisements and things like that they're doing. But I think it's very context specific. In our case, we have so much pilot data because of the pandemic. We've collected 14 months of data. And towards the end of the pilot, it started becoming obvious what the answer is going to be. So the benefits of the adaptive experiment then decline a little bit. And then it's essentially mostly to minimize regret for the people in the experiment, that they're not unnecessarily getting allocated to the control unit at a 50-50 rate, when we know that they should actually be benefiting much more from the kind of like a certain type of treatment. So generally the evidence suggests that they are faster and sometimes substantially so, saving you a lot of money. But I don't think that in our case it's going to be particularly faster, but you can see the simulations in our the AEA Social Science Registry.
Thank you, Berg. Now we have a question for Anya. I'm going to read it from Caroline Tangoren. Was there any heterogeneity in who does or does not seek care when care is required? Also, you mentioned that information constraints seem present in antibiotic adherence. Was adherence higher in more educated households with girls as well, or just for boys? Any thought on what the gender-specific barriers are, since households already have the antibiotics and there isn't a difference in monetary investment required?
Thanks, Carolyn. These are great questions. I'm going to try to make it short. We have little time left. In terms of heterogeneity, so we did not specifically look into heterogeneity much because our study is just not powered to do that. Having said that, we do find some heterogeneity by age of the child, which is not completely surprising. So the youngest children getting by far the most care, and there's a pretty steep drop off towards older ages. What we do see, at least tendentially, I think that is interesting, is that for the very youngest children under 1 year of age, where they are not verbal yet and they cannot explain really what hurts them and so on, we see a lot more a lot more equal care seeking between early and care required days, meaning that it is possible that parents are just less sure what the symptoms mean in a very small child, which suggests that information interventions could be more effective there. But I want to say all of this with the caveat that we don't have enough power to really study this. I also want to add that these households are already some of the poorest in this area, and that is a poor area of Mali and a poor area of the world. So to some degree, maybe we wouldn't expect as much heterogeneity as well. That is very systematic. On your second question, the adherence rates were highest for boys in households with educated household heads, and they were pretty similar for all girls, regardless of household, and for boys in households with uneducated household heads. And the education split is somewhere around 3 years of education. So these are probably about literate versus illiterate household heads. Now, I think your question is a really good one. Why is it that after the antibiotic was already bought, we see this difference? And one interpretation that we had, but it's purely interpretation and not, we don't have like specific data to support this, but we think what could be happening is that male household heads pay more attention to their sons than their daughters. They feel more responsibility for the care of the sons. And because they have the ability to read instructions and so on, they are more able to follow instructions in the antibiotics care. And the reason why we think this is that we don't see any differences, for example, how much of the antibiotic was bought, or if there was any differences in the way it was used with gaps or anything like that. We don't find any other differences besides that, but it's a good question.
Thank you very much, Anya. I think that ends our session. I want to thank all the panelists and the participants who asked questions. And I think now I will give the floor for the next session to Luisa Cardoso de Andrade. Thank you very much. Goodbye.